Hello and welcome to another podcast from Odelle Technology. Today we're joined by Øystein Olsen from Norway. Hello, Øystein.
Hello, it's great to be here. Great to be with you,
Øystein.
Steven. Thank you.
Good to see you. Now, Øystein, I was wondering if you wouldn't mind telling the audience a little bit about yourself, please.
So I am a medical doctor by training. I'm a specialist in public health, but I've worked most of my career in public hospitals in Norway and East Africa. I have my PhD from policy planning and financing, a similar master's degree from London School of Hygiene and Tropical Medicine and London School of Economics. I did wander into petroleum engineering for a while at the Imperial College in London, but I found out that it was better to follow my heart, and I ended up in medicine, particularly in working in health leadership, priority setting. But after 2012, I worked as the Chief Medical Officer at the Emergency Department in Stavanger University Hospital.
Okay, so how did that lead you into private enterprise?
Basically, I wouldn't say it was an accident as such. I'm not a stranger to private enterprise, but having developed the solution that we're going to talk more about later, the innovation office at the hospital in Stavanger University Hospital, figured out that this solution should be available to more hospitals than ours, and there was. At the time, there was an increased attention to trying to increase, let's say, or widen the portfolio of Norwegian public hospitals into both innovation projects and commercialization projects. And so we were introduced through a technology transfer office called Precubator at the time, or Validé as it's called now, and started a commercialization process of our solution in the emergency department, and that took me into private, if you will, enterprise, but it's from a public origin, if you will.
All right, well, let's talk about the company, shall we? Can you tell me a little bit about the beginning of the company and how you got involved?
Well, SmartCrowding is a company based on the visualization application that we made following the process of making what we call plan for high activity. And plan for high activity, we can come back to that, but it was basically a very, very specific need at Stavanger University Hospital to regain control of patient flow through the emergency department and through the hospital as such. And as we developed this solution we called Plan for High Activity, we realized that this solution cannot be based on old technology such as Word and Excel, and it needed modern technology. We introduced ourselves to technology companies in Stavanger, and they helped us to establish SmartCrowding, which is the application. And like I was briefly mentioned, we then established a company around that. First partly owned by the University Hospital, and then after a while we got more investors, and now we're into a full-fledged company with a CEO and CTO and CIO, and developing both the product and the commercial proliferation, or trying to introduce our product to more hospitals because we believe that they also can benefit from it.
Okay, so what actually inspired the creation of SmartCrowding?
Go ahead, yes.
Sorry.
No, that's fine. It's I was going to say it's a little bit of a tragic story, if you will, and maybe that's how many solutions start. We got an external review from the health authorities in Norway, the Norwegian Health Board. They did a review of almost all emergency departments in Norway, and they gave us a pretty harsh feedback in terms of lengths of stay was too long, the number of trained personnel meeting the patient at the front end wasn't enough. Their capacity wasn't high enough. Their competence wasn't good enough. And so we had our director at the time, she was concerned that we need to do something about this. This is very serious. And we thought we were doing a good job in the emergency department, but obviously we were not. And when we started to compare ourselves with other emergency departments, we quickly found out that this was the story for many, many hospitals, both in Norway and Europe and globally. So we were given a relatively free and wide mandate from our hospital director. And she was very concerned about the patient safety issues, the efficiency issues, and not least, I think, the joy in work issues that arise from lack of control of patient safety. And we quickly went into project mode and established through a project cycle the plan for high activity that was our solution in the end.
Okay, so how does smart crowding provide a real-time, or how does it provide real-time insights into hospital capacity and patient flow, and what advantages does this offer over traditional methods like spreadsheets?
First of all, it's important to understand, I think, that we did a thorough job in trying to figure out if we're going to make a plan or a tool to manage patient flow. It needs to be based on evidence. Both in terms of literature, but also in terms of what do our staff, what do health workers need from a tool? Because traditional tools have a tendency to throw up on a wall dashboards with different types of indicators that are more or less useful to health workers. Let's say 7 o'clock in the evening when you really need to make difficult decisions. So we decided to look into the literature, and the literature told us basically there are 4 or 5 elements that are necessary for this type of logistics tool to be useful. And the first is that you need a common language. You need to establish a tool that differentiates and defines accurately what you're talking about. For instance, the term busy. If I ask you, Steven, have you ever been busy? I think
Yes.
you would say yes. Most
Yes.
people would answer yes to that, but I have no idea what that means. You could have told me that you're busy, but I don't know if you are busy. And so when we try to communicate across wards and departments in a hospital, and I ask my neighbor ward, can you help me? I'm really stuck right now. There's really high activity. And the reply is, no, sorry, I'm too busy. That didn't help me at all. And we didn't understand each other in terms of why or why not. What's the reasoning or the definition of busy? And so we needed to basically start defining busyness across the hospital. And once we had a clear definition of what is it that makes you busy and what is it that makes me busy in my ward, then we could start discussing how can we help each other at these different levels of busyness. And that was the first real realization of how a common language is ultimately necessary if you want to talk and discuss and get help from each other across these silos. And the second thing we needed to do was to describe an accurate description of risk, because we know that we want to place ourselves within a risk of economic boundaries. So we know we have a budget. We know we can't just spend anything we want on more personnel or more beds or more infrastructure. And the second thing we also know, and we want to keep within the boundary of workload. And all of us are aware that there is a limit to the workload that you can ask staff to work. But the third limit that we also, as a hospital, want to keep within the boundary of is patient safety and patient risk. Now, the problem with that risk boundary is that we don't really know where that boundary is. And also, we tend to disagree within the hospital on where that boundary is. And so establishing a patient flow tool needs to describe where is the patient safety risk here, and we needed to agree on why should I help you from a patient safety point of view, and we did that with the plan for high activity and smart crowding. And there is another important element here that we needed to understand the logistics of flow, and there's a very good article by Cook and Rasmussen in BMJ Quality that describes how things go freeze up. It's a bit like water molecules. As water turns into ice, everything stops. And this is what happens when patient flow increases. When you get to a certain level, everything really just turns down like ice and stops. And it gets really difficult to get anything done. And then we also needed to understand the difference between normal and abnormal variation. You've probably seen documentaries or series on Netflix from emergency departments in the US or the UK or anywhere, and you will notice how people run around every day and push red buttons and black buttons. It's code red or code black, or every day seems to be a critical and crisis day. However, if you look at the numbers, you will understand that this is normal. Every day is going to look like this tomorrow and next week and next month. So understanding that the patient flow into an emergency department really does increase very dramatically between 12 and 3 or 12 and 4 makes it much easier to manage, because you're not going into crisis mode, you're going into a normal variation mode, and you need to understand how to manage this increased flow. It will happen.
Okay, so how does the smart crowding system provide real-time insights into hospital capacity and patient flow? How does it help the clinician?
It helps the clinician because the clinician, or not every clinician is involved. These are the staff or hospital staff involved are those that are responsible for patient flow. So that would typically be senior doctors or junior doctors in a role in the evening or night, and also senior nurses and flow managers. And it helps them because smart crowding provides indicators that are close to their everyday decision-making dilemmas. So and it gives them information that they have themselves decided that this is what I need. So we make every plan for high activity, we contextualize it to each hospital. Every hospital have their own particularities, if you will, their own ways of describing the roles, their own different wards, their own patient flow, although there are many similarities. And we make sure that the indicators are tailored to each hospital so that they understand that they get the information they need to make difficult choices. And the indicators and the data is real time. It's not retrospective, and this is very important. It's not about the length of stay yesterday or the past 3 hours or the past week. It's about how many beds are available right now, how many infectious disease patients do I have that need to be isolated. How many, if you don't have hospitals with single rooms, then how many rooms are occupied by infectious disease patients and blocking 1 or 2 beds? How many heavy or let's say complicated patients do I have right now? Can I cohort different types of patients into new constellations of rooms, whether it's by sex or by disease or by infection? And all of these indicators are created through an inclusive process with the workers themselves. This is the information I need to make logistics and flow decisions right now. And it gives them real-time data to manage this in their ward or between wards.
So how did smart crowding adapt to the challenges posed by COVID-19 pandemic?
The really interesting thing is that because smart crowding is a really easy uh, program to set up, it doesn't need a lot of integration, and it doesn't feed back into other big systems. So there it's really light-footed, if you will. And you can create new indicators in 5 minutes. You can create new levels and you can establish action plans basically right there and then. So, for instance, at Stavanger University Hospital, smart crowding was used to identify the indicators that were necessary to manage COVID-19. So how many new cases, how many old cases, length of stay, and all the information that the government needed every day that we were mandatory information that we needed to send up through the system. We collected from and through smart crowding, and it gave us both the visualization of each indicator and a plan of action for each indicator. And because it was so easy to set up.
What role does predictive analytics play in this whole thing? If I'm predicting or incorporating, I don't know, weather data or planned events, does it play in anticipating sorts of things like that?
It definitely, we're anticipating moving into that. Today we can anticipate through looking at the curve. For instance, we have an indicator called number of patients coming into the emergency department, or we have another indicator called number of patients that have not been seen by a doctor the past 1 hour. And if these curves are very steep, it shows us that we're moving into a situation that we really need to prevent. We need to manage. The smart crowding indicators are really about managing risk in two ways. The first is to prevent that we actually reach a high level of activity, and the second is to manage the high level of activity once we've reached that stage. However, we have on the planning stages, we have a prediction model or module, sorry, that we are expecting to use AI much more than we have today, particularly as AI is now becoming more and more useful, and we can understand how we can benefit from it. AI will be the next step in terms of improving smart crowding. What we really want to be very careful about is to provide prediction that is not true, if you will, because it's serious business. I mean, if you tell a doctor on call that for the next 3 hours you're going to need 2 more doctors and 3 more nurses, and it doesn't happen, your model isn't good enough, then you're really wasting resources. Or or the opposite could be that your prediction model says that everything's going to flatten out now in the next hour, and you can start relaxing, and it doesn't. And you've sent one doctor home, and you've sent another nurse to another ward, or given them leave. Then that's also very challenging. So we really need to make sure that our prediction model is both piloted well and that we have that we can trust it. And so that's what we're working on right now.
And Øystein, the system works with electronic healthcare record systems and other systems in the hospital?
That's right. So our API basically can communicate with any electronic record system. And the nice thing about smart crowding is that it's a one-way communication. We do not have any patient-sensitive data. We only, let's say this, we take the pulse of the ward. We do not take the pulse of the patient. So in other words, we will tell managers how your ward or your department is doing right now. Your department needs help. Your ward needs help. Your emergency department needs help right now. And we do that by aggregating data. So we aggregate the number of patients in certain categories. For instance, number of patients that haven't been seen by a doctor the past hour. No sensitive data, no GRDP issues, no two-way integration. We don't provide that aggregated indicator back into the electronic patient system because we visualize it on our own platform. And that makes everything so much easier. And it's very, very quick to set up. Once the IT units of a hospital and management are ready, we can set up smart crowding in a few hours, basically.
Is smart crowding finding its way out of Stavanger to other sites in Norway?
We are working on that. So we had a large, if you will, kickoff in March 2023 in Stavanger, where we invited hospitals to look at our solution, and we provided the background for why and how the solution was created. And we thought we would have a few hospitals maybe being interested, but we ended up with 25 hospitals, both from Norway and Sweden, coming to Stavanger and listening to our solution. And there was really a massive positive feedback. So now we're following up on many of these hospitals. We've been to Sahlgrenska University Hospital in Sweden. We've been to several hospitals in Norway, and we're now working with St. Mary's in London. And that's really our main priority right now, is to get into the UK system, because we experience that their challenges are actually much larger than ours right now, and so that makes a lot of sense.
Øystein, can you tell me something about the value platform, please?
Yes. So, making a tool, hospitals, workers, and managers there are so many IT tools out there. There are so many. Everybody wants you to use their tool, and we want people to use our tool. And it's important for us to really underline that our tool is based on managing conflicting values from a health worker point of view. It's really saving the lifesaver is one of our main objectives. And the reason why we say that is because as activity increases and you have a high patient workload, let's say in an emergency department, there are 4 operational values that we have identified that you as a nurse or a doctor are really you're set in some real difficult and tough dilemmas. The first is patient safety and quality. Of course, you want to do a good job doing the best you can for the patient. That's your professional integrity at stake. But the second operational value is efficiency, because you don't want to waste resources, neither as a doctor or nurse, nor as a hospital manager. You will be asked to use resources wisely, both because of your budget limit, but also because if you can save resources, you can also help more patients. But the third value that we want to address through our tool is the value of trust. And we're not talking about trust between the hospital and the patients right now. We're talking about trust within a hospital. Because, like I said, this concept, for instance, of busyness, one of the real main bottlenecks of collaboration within a hospital is lack of trust between wards and between departments. Because we have limited resources, we're going to fight sometimes not to take care of our patients. We're going to try to move patients elsewhere because we don't understand how we're going to manage. We don't have time to go to take our lunch. We don't have time to go to the toilet in many hospitals. And so we're not going to trust anyone who tells us that we're going to send a patient to you unless we really, really believe that this is our patient or we can manage that patient. And so lack of trust is actually a big issue in many hospitals right now. And we want to make sure that our tool, because it communicates through a common language, through pre-identified levels of activity and pre-established and understood and agreed action plans in peacetime, if you will, then we can help each other, trust each other more. And we've seen that happen in Stavanger. And the final operational value is the WHO word, maybe a little bit difficult, but it's about responsiveness. It's an operational value managing expectations, because we also want our tool to manage much better expectations from the patients and expectations from government and medical authorities. And we think that our tool, the way we've set it up, manages these dilemmas. It gives health workers a tool to discuss the conflict that arises between quality, efficiency, trust, and responsiveness in a way that makes everyday work much easier to get through. You get through every day in a way that when you go home from work, you can at least say, I did my best, instead of saying, I really fell short today. I didn't feel I didn't manage my work today. And that, as you probably know, health workers are on the top of indicators that we really don't want to be on top of. We have the highest number of suicidal rates. We have the highest number of post-traumatic stress disorders and psychological and depression. And the Institute for Healthcare Improvement calls it the burning platform. Unless we really start saving the lifesaver, we will have problems recruiting, we will have problems retaining, and the New England Journal of Medicine published an article, I think it was last year, where they talk about the moral injury that happens to global health workers because of these operational values not being managed, and you get this constant feeling of not being good enough at your job. It creates moral injury, basically, to you as a health worker. And that's a really, really serious issue that we want to address with smart crowding.
That's an excellent answer. Thank you very much for that. A lot of things I've never considered, but absolutely. So can you tell me something about the effect of the system inside of the hospital?
Definitely. There are two ways of looking at this. So the first thing we did once we had established the smart crowding and plan for high activity, and we'd run it for a while, we turned around and asked our staff, because they were the ones that initially told us that, it's really difficult to go to work. I really don't feel that I'm doing my work well. And then when we asked them post-intervention, if you will, the feedback was that now I feel that my workload is seen. I am acknowledged for what I do and for what I didn't do. We have a common platform for dialogue, a common platform for improvement, because the action plan can be part of a continuous improvement cycle, PDSA, Plan, Do, Study, Act cycle. Our manager now in the emergency department, he can look at his mobile phone smart crowding solution, and he can see that last night was really, really busy, level 2 and level 3. And so he can ask, or he can compliment the nurses on call yesterday and say that I'm really glad that you managed that really difficult situation so well by making sure that you had 2 nurses staying overtime. Before we had smart crowding, the same manager would come in the morning and would notice that there were 2 nurses that were hired for overtime duty in the evening. And of course, the question would be, was that necessary? It costs a lot of money. Why did you need to get extra resources? Was there, and the answer would be subjective, because it was really busy. And now it's because it was level 2 and level 3, and it turns around the whole dialogue, basically, where you can now acknowledge high activity and acknowledge correct interventions, while previously we would argue about the correct interventions based on subjective experiences of busyness. On the other hand, we also saw some very quantitative results. We saw the reduction of corridor patients, which was a really, really big problem in Stavanger. We had many patients on corridor. We had about 1,000 patient days per month, and through the intervention period, that reduced to about 300. We also saw the cost of temporary staff being hired going down from about 800,000 Norwegian kroners to 200,000 Norwegian kroners. We saw the length of stay at the emergency department go down from about 4 to 3.5 hours per patient, which is a large improvement in an emergency department. And we saw the length of stay in the wards, in the patient wards, go down from 5.5 to 4.5 days, which is 1 whole day actually reduction, which is a massive reduction if you both financially and in terms of patient flow. So we didn't, unfortunately, do a complete research protocol on that. So that's what we want to start now with St. Mary's or other partners. But from our data, that's what we observed, and we were very happy with those results.
Excellent. All right. Well, thank you very much for that. It's been a pleasure meeting you today. I wanted to thank you very much for what you've done. And I think the work at St. Mary's will be a bit of a game changer for the National Health Service. I hope it is. I've been watching it myself, and I know that it's already producing some good results. So thank you very much for your efforts. All the very best, and I hope to talk to you again in 6 months' time to see where we are with St. Mary's.
Yeah, that would be very, very interesting. We're right now working on the research protocol. We're hoping to establish a pilot project there, and likewise, Steven, it was really good to talk to you. Thank you for being invited to your podcast, and all the best to you as well.
Thank you, Øystein. Take care.
Bye-bye.